Let me set up the slide. So can everyone see the slides at the moment?
Yeah, that's good. Yeah.
Well, good morning, everyone. So today we'll be going through a bit of men's health and genitourinary. Men's health and genitourinary conditions and approaches. So there's a lot of very, GP specific and R1 topics in this space. Especially around STIs and things like erectile dysfunction, BPH. And we'll also be going through some presentations like scrotal swellings and haematuria that are quite important to know in GP, but also generally. So starting off with some men's health, erectile dysfunction is one of the key conditions here. So the etiologies of erectile dysfunction is a mix of organic and psychogenic. Organic is more common, as the slide says, and sort of vascular causes are probably the most common. You might have heard your lecturers talk about erectile dysfunction being the canary in the coal mine for cardiovascular disease and atherosclerotic arterial disease. And it's definitely, I guess, one of the things to think about, or one of the most important things to think about with erectile dysfunction. Is there any other sort of arterial disease or cardiac disease? There's also neurologically mediated erectile dysfunction that can occur with peripheral neuropathy or after surgery, endocrine causes, things like androgen deficiency in particular, as well as psychogenic causes, which we'll go into a bit more in the history and examination section. And yeah, the key risk factors really align with that. It's also important to know that there are a few drugs that can cause erectile dysfunction, most notably antidepressants, antipsychotics, and beta blockers, and thiazide diuretics. So the history of erectile dysfunction, the approach here is to obviously get a good sense of exactly what's going on, to talk about frequency, duration, etc. But then we start looking into trying to differentiate the different causes of erectile dysfunction and assess for any other sexual issues that might be happening. So but to do that, we look at is the problem with initiating an erection or maintaining an erection? Is there an issue with libido? Is there an issue with premature ejaculation? Does the patient have cardiovascular risk factors? Are there any other unusual signs or symptoms suggestive of endocrine disease? Is there any psychological stresses in their life? And the exam sort of reflects this. There's some slightly unusual things in here, such as plaques and erectile tissue and Peyronie's disease. Just a small thing if you want to know that for brownie points, I guess. I think I mentioned in the lectures, and the signs of androgen insufficiency syndrome. And then on the right here, so we've got a really good summary diagram of the differences between psychogenic and organic erectile dysfunction. So whilst organic erectile dysfunction is generally constant and there's no sort of additional spontaneous nocturnal or morning erections, in psychogenic erections, because it's a sort of more of a mental rather than a physical problem with the erectile system, you can still get spontaneous erections and it sort of may fluctuate as well. And then just looking at management and investigations, so doing all your basic blood tests, cardiac screening, as well as morning serum testosterone. The morning part, as I found out quite recently, is actually quite important because testosterone varies with circadian rhythms. And then things like TSH and prolactin. So with management, you want to make sure you've got all the lifestyle things down pat, managing cardiovascular risk, psychotherapy, counseling, whether or not any sort of couples counseling is necessary as well. And then with pharmacological means, the three major methods are phosphodiesterase inhibitors, intracavernosal injections, and prostheses, or not just therapy implants, but there's also kind of like vacuum device that can stimulate an erection. Importantly, PDE5 inhibitors are contraindicated with nitrates. So someone with chronic coronary artery disease or a previous AMI who's on GTN or some other form of nitrates, don't give them PDE5 inhibitors. Just priapism as well is a major side effect of all of these methods. If it's longer than 4 hours, that's an emergency and they need to go. If it lasts longer than 4 hours, that's an emergency and they need to go to the ED. And yeah, for intracavernosal injections, the main thing you need to know is, again, they've got the highest risk of priapism and then just a general understanding of what prostheses and surgery might involve in making devices. This is a bit of a diagram about the physiology of the erectile functions, but in the sake of time, we probably won't go through that today. But essentially, with PDE5 inhibitors, they cause, I guess, vasodilation of arterioles, which results in engorgement of this cavernous space, and then this compresses on the venous plexus, which basically stops outflow. And then, so a lot of blood going in, not much blood going out, and that stimulates an erection. And yeah, it's just a subtle plug for GPSN resources. Okay, so prostate issues. So there's BPH and prostate cancer. So BPH, we know, is benign, quite common, affecting 25% of men aged over 50. Major risk factors are age, family history, and being sedentary, as well as or overweight, as well as some other drugs. As a good sort of mnemonic for the symptoms, which is fun-wise. So sort of fun refers to, I guess, storage type symptoms. So that's when the bladder isn't able to hold enough urine. So things like frequency, urgency, nocturia. And with voiding, so that's got to do with flow issues, stream issues, post-void dribbling, as well as like difficulty initiating erections, urination. So with the signs, important to know the DIE features that it's like classically smooth and firm, so there's no nodules, unlike prostate cancer. And with complications, you can get urinary retention, and acute retention crisis can be quite problematic, as well as things like micturition affliction, syncope, and recurrent UTIs as well. So for investigations, just making sure you do urinalysis, as well as your midstream urine, and then getting on top of your PSAs, because it's very difficult to differentiate between prostate cancer and BPH solely on history and examination. So it is important to get that PSA level. And then if there's severe urinary symptoms or retention or an elevated creatinine, making sure you get the ultrasound to check the for any, I guess, backflow or damage to the rest of the urinary tract. For management, once again, we begin with non-pharmacological strategies such as reassurance. Once all the workup is done, so it's not cancerous, as well as reducing caffeine, fluids, alcohol, things that increase urination. And then for bothersome cases, so that's usually defined there's a few scales that can be used to determine this. I can't remember exactly what they're called off the top of my head, but there's a few scales which they do talk about in the GP. And if you score above a certain mark on those scales, they will recommend pharmacological treatment. So the first line is tamsulosin, and then you can add on dutasteride, which is a sort of an androgen type of inhibitor, receptor inhibitor. And then you can look at urological referral as well as a combination of those drugs. Now, prostate cancer is the malignant sort of counterpart to BPH, and it's the second most commonly diagnosed cancer in men after non-melanoma skin cancers, so it's very common. In particular, family history is quite important, and that includes a family history of breast cancer. Just with PSA screening, so you might have seen this tool, which really visually encapsulates the kind of benefits and harms of PSA screening. So at the moment, the consensus is that it's not recommended for general patients unless there are additional risk factors or the patient is really keen to have screening themselves. As we talked about with the DIEs, you can see asymmetry and nodules. A very hard nodular prostate is the classic finding. but this is actually quite uncommon. Most cases, probably it's hard to feel exactly what the prostate feels like. And there's also, it's important to look for symptoms of advanced local disease and metastasis. So asking about back pain, bone pain, constitutional symptoms, as well as haematuria and bowel changes as well. Now, just with the investigations, so if the PSA does come back abnormal, it is important to get something called a free to total PSA ratio, which helps, I guess, stratify risk, and to also repeat the PSA later, because an abnormal PSA can also be caused by things like UTIs and trauma. So just one reading is not enough to really raise suspicion of prostate cancer. And the management is really specialist guided, urological referral. So if there's an elevated PSA or a significant increase over time, then that warrants referral, even if the actual levels aren't too high, as well as other suspicious findings. And the evaluation and referral process usually consists of ordering a prostate MRI or an ultrasound to give to specialists who then look at whether there's a need for biopsy. And then leading further to that, radical prostatectomies and deprivation therapy. So, cool. Got a little multiple choice question. So I'll just give you a minute to do that. People could please put the answer in the chat. That would be great. Okay, so I'm getting a couple of C's, which is very good. So the answer is indeed C. So well done. You guys know your stuff and you're listening. So yeah, definitely next step is to repeat the PSA in order for some imaging rather than jumping ahead to refer or order an MRI without kind of incomplete assessment of the PSA. And yeah, just with Geodart, that's as you discussed, that's also for BPH and the second line treatment as well. Another question. Wait for a few more analyses. Okay, so there's a bit of a mix here. There's some B's, a few B's, and A mixed in there as well. So the answer is B. So I think perhaps what the point of this question was highlighting is, I guess, in GP as well, it's important to remember some of the third year things, which we'll go through in the next slide, in the segue to the next slide. And the treatment of urosepsis is either IV amoxicillin and gentamicin or IV ceftriaxone, which is not an option here. Yeah, it's just a good thing to know. And also it's perhaps reassuring that, regardless of the way the question is packaged, as long as there is urosepsis in the patient, the management sort of is pretty much the same. So just with UTIs and urosepsis, a bit quick revision from 30 years, so more common in females and with increase in age, or with an IVC in particular, as well as other pre-existing kind of issues with the urinary tract. So these complicating features. Now, the most common cause is E. coli, and then after that, things like Klebsiella, Pseudomonas, Candida, and Staph saprophyticus, and then Trifococci. And these two, especially with catheter-associated UTIs, are more common. Symptoms of the classic triad of dysuria, frequency, and urgency, as well as suprapubic pain for cystitis or plate pain if there's pyelonephritis, and then keeping an eye out for signs of sepsis as well. Investigation, urine dipstick, midstream urine, and then with the recurrent UTIs, you want to sort of investigate for structural issues via an ultrasound. Now, the management, so if there is suspected pyelonephritis or sepsis, you refer to the ED, and then for non-severe pyelonephritis, there is no fever, the patient will get oral augmentin. For severe pyelonephritis, the choices are either IV gentamicin and amoxicillin or IV ceftriaxone. For uncomplicated non-severe UTIs, so that's kind of your run-of-the-mill, no fever, maybe some cystitis is the only thing that's found there. Then you use primethylprednisolone or cefalexin or nitrofurantoin as a first-line agent. And similarly for acute prostatitis, you use a similar antibiotic regimen, although the treatment is a bit longer. So, STIs, another very high-yield topic. So the Australian STI guidelines and the GPSN summary sheets really encapsulate all the key knowledge here very well. So just to talk about the standard asymptomatic checkup for STIs, but for the history, we like to talk about the 6 Ps. So we asked about partners, practices, protection, pregnancy, past history of STIs, as well as prevention of harm or preferences for treatment and discussion. And as for the blood tests, so in regardless of whether the patient is in a low risk or high risk group, we should do HIV, syphilis, hepatitis B serology, as well as chlamydia and gonorrhea, first pass urine or vaginal swabs. Hepatitis C testing is only performed if there are specific risk factors for hepatitis C, such as HIV co-infection, IV drug use, like unclean tattoos, or being in sexual contact with someone with hepatitis C. And as we've briefly outlined, so asymptomatic testing is indicated for all people who do request the testing. If they want it, you should order the whole thing. Similarly, it's also indicated for people with new sexual partners or other slightly higher risk factors for STIs, as well as suspected STI exposure. Now, with special subpopulations, there are increased testing requirements. So, especially for men who have sex with men, the guidelines say to regularly test every 3 months, as opposed to a sort of ad hoc or on request basis. And with these other groups, so pregnant people, sure the people in Lism have told you about the specific requirements there. And for sex workers, that does depend on exposures, and that guideline for that is a bit more complicated. So don't think they'll ask you about it in exams, but definitely for MSMs and pregnant people, it's good to know what to do. So here's a question to get you thinking about that. Okay, so going to be seeing a few D's. So well done. Yes, that is the correct answer. So being a man who has sex with men, is important to repeat that testing every 3 months. And that's sort of goes through that in a bit more detail. Now, just the thing with men who have sex with men, or really anyone who routinely practices, I guess, oral anal sex on history, it is important to swab the oropharyngeal and anorectal regions, as well as doing a first pass urine, because the infective organism, the STI, could be in those areas instead. So just for the management of specific STIs, starting off with gonorrhea. So it's more common in men than women. Overall, the rates of gonorrhea are lower than the rates of chlamydia. The main symptoms are a mucopurulent urethral discharge, as well as dysuria, and with anorectal gonorrhea, you can get anorectal symptoms such as purulent discharge and pain on defecation. There are a number of complications of gonorrhea as well, including gonococcal conjunctivitis, septic arthritis, disseminated gonococcal disease, as well as ophthalmia neonatorum, which the visiting people might tell you a bit more about. The investigation for gonorrhea involves a first pass urine, which you perform a PCR or a nucleic acid amplification test, an NAAT on. And yeah, that's fine with the swabs. You also send off the PCR and culture. Now, it is important with gonorrhea to not just do the PCR, but to also do the culture, because that tells you the antibiotic sensitivities. PCR work. And then the treatment is iron ceftriaxone and a single dose of oral azithromycin stat immediately. And that's, yeah, that's so the patient doesn't want to keep coming back for people with treatments. Chlamydia, on the other hand, so it's more common in women than men. It's overall more common in gonorrhea, and it's usually asymptomatic. You can also get symptoms of urethritis, but the discharge there is usually more mucoid rather than mucopurulent. The complications of chlamydia can include reactive arthritis as well as epidermolysis. Similarly, with investigations in men, you do a first pass urine, and in women, you would do an endocervical swab, both of which you send off for PCR. You can also do a hard vaginal swab or self-collected vaginal swab as well. Now, the management of chlamydia, so there's doxycycline for 7 days or azithromycin 1 gram on the spot. And the azithromycin 1 gram option is if the patient is perhaps unlikely to adhere to a regimen lasting at least 7 days. Now, with STIs in general, there are, I guess, important general non-pharmacological principles, such as contact tracing, so notifying health department, tracing partners from the last 6 months or 2 months for gonorrhea, and then, of course, not having sex for a 7 to 14-day period until the infection is resolved. And with chlamydia as well, there is a test for cure and a test for reinfection that you can do. Now, I do have a question in the chat. So, yeah, so are chlamydia and gonorrhea both notifiable? I believe they are, but it would probably be best to double check that one as well. So with mycoplasma, it has a similar prevalence to chlamydia, so it is quite common, and it can cause the similar clinical syndromes as chlamydia and gonorrhea, such as urethritis, cervicitis, and PID. So just with mycoplasma, the thing to remember is a vaginal swab is better than an endocervical swab. And this is sort of grayed out. So it's not as important to know the management of mycoplasma, but it's very similar to that for chlamydia. So doxycycline, and then you also can follow it by azithromycin or moxifloxacin, which is the point of difference there. And then there's also a test of cure as well for mycoplasma, although you don't need a test for reinfection. Yeah. So it's another multiple choice question. So if you could please put your answers in the chat once again. Yeah, so very good. Seeing most of the areas in all of these. So the correct answer was for the answer, but the correct answer is A. So you have to give both ceftriaxone and azithromycin for gonorrhea. Just with E, just put an asterisk there. So I haven't got a slide on this, but that is a treatment for trichomoniasis, which is another STI. And the buzzwords for that are green discharge, as well as something called a strawberry cervix. So that's a very red cervix with a lot of little punctate dots on it. So going into STIs that cause ulcers. So there's herpes, syphilis, LGV, and most commonly genital warts. Starting off with herpes simplex, being genital ulcers. The symptoms of herpes and signs of herpes simplex. So we start off, there's often a very neuropathic quality to the pain. And then there's development of fluid-filled vesicles, which can be quite painful, and then these can become ulcerated and become painful ulcers. You can also get inguinal lymphadenopathy there. Complications include neurogenic bladder, as well as enhanced HIV transmission. I guess if you've got an infection, the damage to the protective barriers of the skin and the immune system dysregulation makes it more likely for another infection to come in, as well as neonatal herpes simplex virus. So investigation, it's important to swab the base of the ulcer, try and get some of the ulcer fluid or the vesicle fluid, and then send that off for PCR for the virus. Management, so non-pharmacological treatments include analgesia, topical lignocaine is probably the best option. So we want to localize our analgesia, and then saline baths and other bandages as appropriate. We also prescribe antivirals, so valacyclovir, famciclovir, or acyclovir. I think valacyclovir is the one that's the most preferred in the guidelines. And you follow up in 1 week, but with HSV, there's no need for contact tracing or testing for reinfection or testing for cure. So syphilis. Syphilis is, I guess, particularly a condition for several high-risk groups, such as men who have sex with men and in Indigenous populations. So about syphilis, there's 3 stages of syphilis. There's primary, secondary, and tertiary syphilis. Not so important now, probably, in exams, but primary syphilis sort of starts off with these painless chancres as opposed to HSV ulcers, which are painful, and it's highly infectious. And then secondary syphilis is where there's a rash and systemic symptoms. And then you can get things like hepatitis and hepatomegaly and neurological symptoms as well. Tertiary syphilis is sort of when it really starts to damage the end organs. So you can get inflammation of the aorta. You can get tabes dorsalis, which is which is a proprioception vibration based issue, and also some motor component as well of the spinal cord, the spinal cord damage due to syphilis, as well as gummi, which are like invasive nodular lesions that I guess quite nasty, kind of makes the skin go very nodular and bumpy. So the diagnosis of syphilis is based off serology. There are some very good diagrams in the STI guidelines on this. but I guess the key point is to try and understand the difference between these EIAs, the TPPA, the TPHA, as well as the RPR. So the EIA, the TPPA, TPHA, and antibody-based tests that are used for screening. And then if you sort of want to confirm syphilis and to identify the stage of a patient's syphilis, you then do the RPR as well. And if the ulcer is present, that gives you like if ulcers are present, gives you a good opportunity to do a swab and then send that off for PCR for further confirmation. Now, the mainstay treatment is benzathine penicillin or benpen, especially for primary and secondary syphilis. The treatment for tertiary syphilis is a bit more complex, and there's a massive flowchart in the guidelines. It's got recommendations what to do for tertiary and latent syphilis as well. So you can look at those if you're interested, but probably not as important as just being aware of how to test for syphilis and primary and secondary syphilis treatment. So on the other ulcerating conditions is LGV or lymphogranuloma venereum. So that's more common also in men who have sex with men. It's caused by certain serovars of the mediatric chromatins, also by like a virus similar to chlamydia, shall we say. And there's 3 stages of LGV. So it begins with a genital ulcer, and then after several weeks, it can progress to tender regional lymphadenopathy, as shown in this picture. And these very tender, inflamed lymph nodes are called buloes. And then with in the tertiary stages, after perhaps several months, when this inflammation settles down, you can get fibrosis and strictures. So the last, I guess, but perhaps the most common form of ulcerating lesion type STI is HPV or common genital warts. So smoking and immunosuppression are very big risk factors for this. The symptoms of HPV include perianal itch, PR bleeding, as well as noticeable warts. They often, I think the key point here is that they often are itchy, but not very painful. And the discomfort perhaps comes mainly from their appearance and the, I guess, psychosocial and sexual implications of that. With men, you can also get dysuria, and that can also happen in women, and you can also see cervical lesions on the speculum in women as well. So with the HPV diagnosis, sorry, this is from an old slide, so we don't really do the pap smears anymore, but we do something called a co-test. So that's your liquid-based cytology plus your viral, I guess, finding out the viral type of the virus using the DNA and genetic testing. The management of HPV, now it's important to differentiate like a simple genital wart from cervical cancer or sort of vaginal or anorectal forms of cancer caused by HPV. But if it is a simple genital wart, the mainstays of treatments can include cryotherapy as well as imiquimod or podophyllin, which are immune modulators that reduce the size of these warts. And with HIV, so this is more like a 3rd year thing, but I guess there's a few key points here with HIV screening. So there's a few different components involved. It's important to know how to interpret them. So P24 antigen, HIV antibodies, knowing the difference, and then confirming the Western blot. The important paradigm here, I guess, is to reassure patients that undetectable equals untransmissible, I'm sure you've heard of, or U equals U, and the importance of keeping, regularly checking CD4 counts and making sure a patient is adherent with their regimens. So just a quick question here. If you could once again put your answer in the chat, that'd be great. Okay, so there's a mix of answers with this one. So there's a mix of A's, C's, and D's. I think they are all quite reasonable options, especially A and D. Does anyone want to perhaps start by saying in the chat what they think the diagnosis is? Yeah, that's very close. So we've got a few answers saying genital warts, and then a couple of molluscum contagiosum. So this is molluscum contagiosum. Sorry, slides. And the correct answer is A, therefore. So just with molluscum, it's a condition that is spread by skin-to-skin contact. And the most common features of these, kind of the buzzwordy papules with a central umbilication. So there's a little sort of dot or depression in the middle, and that's a hallmark sign of molluscum. So as a result, the treatment here differs from HSV and HPV. Sorry. So the management, we don't need to do a viral swab to identify the specific etiology because of these quite characteristic clinical features. And these are usually not very bothersome. And they usually don't cause invasive disease. So it's not necessarily something that's super grave as a diagnosis. However, the cosmetic appearance of these and the physical, I guess, manifestation can be quite undesirable for patients. So you can offer cryotherapy or curative to remove these lesions. Okay, so now going off to some approaches. So this time it's on scrotal swellings first up. Now, we've got a question here just to get us thinking. So if you could put your answers in the chat, that would be great. Yep, so got a few C's coming across, so very good. The answer is D. So for the evaluation of testicular lumps, so we'll start off by some general principles and histories and exams. So it's important to get your good like WWPQ AA history about the duration, the size, shape, and so forth. And if it's there all the time or if it comes and goes. But I think some key things to look at for testicular lumps is it transilluminable, because that tells you if it's fluid or liquid. Also, like with the shape and if it comes and goes, it's important to know if it comes and goes with standing, from standing to lying down, or with the Valsalva maneuver, because of that tells you the etiology. And with an exam, it's good to know what structure the mass is attached to, because that can help you identify if it's coming from above, from the bowel, being a hernia, or if it's from the testis, such as a testicular cancer, perhaps. And then as well, if it's something like a varicocele that is from the veins instead around the testis. So just to go through the main painless lumps, so hydrocele is probably one of the more common lumps. So this surrounds the testis. It's a fluid-filled structure. And this is, I guess, the main differential diagnosis for testicular cancer. So testicular cancer is also in the testis, but it's within the testis, and it's a hard, usually painless lump. It does not transilluminate because it's solid-filled, and it occurs most commonly in young men. Right. With varicoceles, so the classic sign is a bag of worm sign, separate from the testis and the epididymis. So this is a venous lump, venous engorgement, that is more prominent when standing or with valsalva maneuver due to the impact of those on blood flow. And it can also be associated with subfertility as well. So it's good to get those diagnosed and treated properly by a urologist, even if it's not malignant. We also get epididymal cysts as well as inguinal hernias. So just remembering some key things from third year about the cough impulse test, reducibility, and then palpating to try and feel the upper border of the testis and palpating the inguinal rings as well. So with painful lumps, this is more of an ED type presentation. So the key differentials here, testicular torsion, carcerated hernia, and epididymo-orchitis. So testicular torsions and carcerated hernias are surgical emergencies. With testicular torsion, the pain is usually sudden. It's a very severe pain. Often patients can't walk or touch a testis at all. There's some buzzwordy examination findings, such as a high riding testis, an absent premasteric reflex, and negative Pren sign. So Pren sign is when the testis is elevated. A positive Pren sign means pain is relieved by elevation, but negative means it's not. And then in contrast with incarcerated hernias, you can't feel the upper border of the swelling, and the test is also very painful, and then you can also get bowel changes, such as symptoms of bowel obstruction, which really give away the diagnosis in this case. There's also epididymo-orchitis, which is a less urgent presentation, but it's an important differential because it also features testicular pain and erythema. So this pain is less intense, it's more of a gradual onset. And importantly, the Pren sign is positive and the premasteric reflex is present. And it's often associated with a history of sexual activity, which is something that's important to ask about when trying to differentiate between these. There's a few other conditions as well, including torsion of a testicular appendage. So the buzzword is like a blue dot sign on the upper pole of the testis. And then testicular rupture, which is seen with trauma. So speeding through to haematuria now. So again, another EMQ, so please put your answers in the chat. That would be great. Okay, so there's a few answers. There's some C's, some D's, and some J's. Now, does anyone want to suggest what the diagnosis here might be? And then we can perhaps work through those answers. Oh, yes, very good. Someone has said exercise-induced hematuria. So that is definitely the correct diagnosis. Or potential rhabdomyolysis. So, which actually, no, it's probably less likely than non-hemolyzed blood. But anyway, we'll go with exercise-induced hematuria. So, we'll talk about it a bit more in the subsequent slides. But I think with these types of questions, there's a lot of different options. I think just going back to the diagnosis and then thinking about what the question's asking you. So the next most appropriate step. So you want the least invasive investigation, which is a urine dipstick. There's a few people who answered C's and D's. So C is, I mean, it will probably be done, but it's not going to be the most useful when identifying your diagnosis. And that's a similar case for D. So with hematuria, I think there's a few different ways you can classify this. You can look at the location of the hematuria, whether it's in the bladder, in the urethra, vagina, or the penis, and then moving up if it's in the kidneys, or as well in men the prostate. And then we can also look at if the etiology is something that's, I guess, an acute problem, a malignant problem, an inflammatory problem, or a sort of obstructive and old age type problem. So with the transient problems, the key issues, the key diagnoses include exercise-induced hematuria, urethral trauma, as well as vaginal and uteral trauma, prolapse, vaginal apathy, especially in postmenopausal women. And then in malignant hematuria, so painless hematuria is a red flag for malignancy, especially chronic painless hematuria. And the cancers that we're thinking about are urothelial or bladder cancer, prostate cancer, and renal cell carcinoma. In particular, on the, sorry, jumping between the two parts of the slide, but on the right, increasing age, smoking, and occupational exposure to benzene dyes and paints are risk factors for bladder cancer in particular. So it's probably the cancer that we're the most worried about out of these three. And then with infectious and inflammatory diseases, so you can get radiation cystitis, pyelonephritis, urethritis, and also urethral carbuncle, which is a skin lesion on the urethra, as well as renal, I guess, inflammatory diseases. So IgA, thin basement membrane disease, there are all forms of glomerulonephritis, in particular the nephritic form, nephritic syndrome. And you can also get PCKD, the cysts and polycystic kidney disease can cause hematuria as well. With obstructive causes, whether or not a BPH or prostate cancer could cause hematuria, as well as classically very painful urolithiasis or kidney stone. And just with the investigations, I have a question in the chat. How will you approach a differential diagnosis for hemolyzed versus non-hemolyzed blood in the urine? Now, that is a very good question. So with hemolyzed blood indicates that the blood has probably come through a structure from higher up, and it's sort of, the blood has been, I guess, forced through a narrow area, and the blood cells have therefore hemolyzed and broken down. So some of the differentials here could involve things like, especially your renal diseases, such as like casts and renal casts in certain forms of nephritic syndrome, as well as potentially with trauma as well, you can get hemolyzed blood. Hopefully that answers your question. But yes, more than happy to talk about that more if you've still got questions on that. So with the investigations and management, the mainstay is, of course, the midstream urine, sending that for microscopy, culture, and serology. So in this flow chart, taken from the College of General Practitioners guidelines, if a benign cause is suspected or you found that's UTI, transient hematuria, then you treat that particular cause and then do a repeat within 6 weeks. However, if the cause is perhaps, if you're suspecting malignancy or a renal issue, then we could, then we analyze if there's microscopic or macroscopic hematuria. If there's microscopic hematuria, you immediately look at imaging to try and rule out malignancy and an urgent neurological referral for cystoscopy. If there's microscopic hematuria, so this could potentially be seen with, very minor levels of trauma or UTI, which would come here. But anyway, with microscopic hematuria, we do a risk stratification method. So if there's no other risk factors, then we consider low risk and then come back to it, most likely being a transient or UTI cause. And then if there are risk factors for malignancy, or if there's a lot of, if the microscopic hematuria is significant, and also if it's a recurring problem, Then we would look to further evaluation with imaging and cystoscopy. Can you repeat which conditions cause hemolyzed versus non-hemolyzed? Sure. So with non-hemolyzed, it could be things like exercise-induced hematuria or like lower urinary tract causes, such as bladder cancer and prostate, perhaps things like prostatitis or prostate cancer, but mainly exercise-induced and bladder cancer are the main ones you're looking at. With hemolyzed urine, so that usually involves from my understanding, a renal nephritic type pathology. So that's your things like IgA nephropathy, and as I said on the slide before, thin basement membrane disease, like ANCA-associated glomerulonephritis, things like that. Does that make sense? I've asked that question. Yeah, perfect. So thank you very much for listening. Happy to take any questions if anyone's got any more.